right now we're kind of in that holding pattern where everything is either telehealth or emergency care. How much longer can we go in this direction where patients who need their routine stuff in dermatology or other fields, especially oncology, can't see their doctor in person?
Yeah, I think you're referring to the other pandemics we're experiencing, the mental health pandemic, the pandemics relating to other areas of medicine where patients who need treatment and to be seen by their physicians to maintain stability, they're not getting in, or even worse, they're not going in because they're afraid to go in, and then they suffer morbidity or immortality associated with not being seen. I think, at least in DC, I can say, I think we're starting to see the light at the end of the tunnel. We're starting to see a decline in hospital cases, and I can share with you that we are already in discussions about how do we reopen in a meaningful way that's both safe but also allowing us to do those more routine things. Being that it's Skin Cancer Awareness Month, the first thing that was kicked to the curb were total body skin exams, skin cancer surveillance for the average patient. But even, I'd say, for patients who are at higher risk, they are being told to postpone, given that the risk of coming in outweighs the risk of not being seen. But you're right, this has been dragging on for some time. We gotta think about what we're gonna do next. But I'm starting to see plans in place to do this in a safe way, whether a patient has to be tested before coming in, depending on what they're coming in for, how we stagger the visits, maintaining PPE, surgical mask, gloves at all times on both sides of the aisle, the practitioner and the patient. So I would not be surprised within the next month we start seeing these patients coming in with greater frequency, not where we were in any respect, in the past, but I think we're going to start opening up much more. I can speak at least in DC and Maryland. I think we're starting to see it elsewhere as well. So I think there is hope. That said, let's say that's not the case, and you have, your God knows how many patients who need full bodies. The recommendation I've been giving is that it's a partner. Whether we were doing telehealth or not, any patient who comes to see me who gets a full body, I say that this is one part. The other part is you doing self-checks every month, every other month. And you're looking for change over time or something that just not fit right with whatever else is there. And if you find that, then you come back in, when in this case would be telehealth. So what I'm finding is patients who would normally just come in yearly, if they pick up something that they think is weird or they don't know what it is, we do a telehealth visit. This could include what we're doing right now, audiovisual, as well as a high definition photo, because it is hard to see lesions through video. And if I can't make heads or tails with all those resources, I'm bringing them in for that component. But what I think is being missed here is that surveillance is still happening. They're looking themselves over. They're engaging a partner to look themselves over. We are talking about these things. We're focusing on unique spots and then bringing them still in a safe way to identify whether it is something that needs a biopsy or not. So it's certainly a modified approach. It's probably not as efficient as just doing full bodies around the clock, but it's not all or none. I think we do have a compromise in the middle ground.